I am Dr. Savitha Lakshmi from the Department of Oral and Maxillofacial Surgery. Today we will be discussing the anatomy of facial spaces. This is an essential topic in understanding the spread of infections in the head and neck region. The cheek is composed of multiple anatomical layers, each serving a unique structural and functional role. From the outer skin to the inner oral mucosa, these layers include fat, fascia, muscles and connective tissues. Understanding these layers is crucial for surgical planning and the management of facial infections or trauma. Skin is the outermost layer of the cheek. Subcutaneous fat is the layer of fat present just beneath the skin. SMAS is nothing but a superficial musculo-aponeurotic system, which is a continuous fibrous network that includes the mimetic muscles. These muscles are responsible for facial expressions. Fat and fibrous tissue. Subsmass fat is the layer of fat located superficial to the SMAS. Deep facial fascia is a fibrous connective tissue layer that separates the buccal fat pad from the superficial layers. Buccal fat pad is a mass of fat located between the buccinator and superficial muscles of the face. Buccinator is a thin flat muscle that forms the wall of the cheek and is important for chewing, sucking and whistling. Oral mucosa is the innermost layer of the oral cavity. The term fascia is used to describe broad sheets of dense connective tissue whose function is to separate structures that must pass over each other during movement, cover muscles and glands. It serves as a pathway for the course of vascular and neural structures. The fascia of the head and neck are broadly classified into two main types, superficial fascia and deep cervical fascia. Superficial fascia is a loose connective tissue layer that contains fat, superficial veins, cutaneous nerves and muscles of facial expression. Deep cervical fascia is further divided into three layers: anterior, middle and posterior. Anterior layer includes the investing fascia, which encloses the entire neck and surrounds the sternocleidomastoid and trapezius muscle. It also includes the parotidomasseteric fascia around the parotid gland and masseter, and the temporal fascia covering the temporalis. The middle fascia is subdivided into muscular and visceral divisions. The muscular division includes the sternohyoid, omohyoid and sternothyroid, thyrohyoid layers, while the visceral division consists of the buccopharyngeal fascia surrounding the pharynx, pretracheal fascia enclosing the trachea and thyroid gland, and the retropharyngeal fascia located behind the pharynx. The posterior layer contains the ala fascia, which is a thin layer between the retropharyngeal and prevertebral fascia, and the prevertebral fascia itself covers the vertebral column and associated muscles. Superficial fascia is a layer of fatty connective tissue beneath the skin contains the muscle of facial expression. This layer also contains cutaneous nerves, blood vessels, lymphatic vessels, superficial lymph nodes and a variable amount of fat. Anterolaterally, it is associated with the platysma muscle. In conditions like necrotizing fasciitis, there may be a thrombosis of vessels in this layer, and involvement of the platysma can lead to its paralysis. The investing fascia is the anterior layer of the deep cervical fascia, and it forms a continuous sheath that surrounds the entire neck. Let's look at its attachment. Posteriorly, it attaches to the spinous process of C7 and ligamentum nuchae. Anteriorly, it encloses the infrahyoid muscles. Superiorly, it is attached to the external occipital protuberance and the superior nuchal line. Laterally, it extends to the mastoid process and the zygomatic arch. Inferiorly, it is anchored to the spine of scapula, clavicle, acromion and the manubrium of the sternum. This layer plays a key role in enclosing muscles like trapezius and sternocleidomastoid and forms compartments that guides the spread of infections in the neck. Investing fascia is the outermost layer of the deep cervical fascia, which is pierced by several important structures. These include the external and anterior jugular veins, specifically the nerves that pierce the investing fascia or the lesser occipital nerve, great auricular nerve, transverse cervical nerve and the supraclavicular nerves. Essentially, all branches of cervical plexus emerge through this layer to reach the skin and superficial structures of the head and neck. Parotidomasseteric fascia is a part of the anterior layer of the deep cervical fascia that covers the parotid gland and extends over the masseter muscle. Its boundaries are as follows. Anteriorly, it is related to the superficial surface of the masseter muscle. Posteriorly, it blunts with the fascia over the parotid gland. Medially, it extends towards the medial surface of the medial pterygoid muscle. It also covers the superficial surface of the temporalis muscle. Superiorly, it is bounded by the superficial temporal crest. Temporal fascia is a strong fibrous layer that covers the temporalis muscle and lies above the zygomatic arch. It plays an important role in enclosing the temporal fat pad, which is continuous with an extension of the buccal fat pad. Additionally, it is important to note that in deep neck anatomy, the suprasternal space of Burns is located in the lower neck, but mentioned here to highlight the continuity of facial planes and fat compartments in the head and neck region. The middle layer of the deep cervical fascia plays a vital role in enclosing and supporting the infrahyoid muscles and visceral structures in the neck. The sternohyoid, omohyoid and sternothyroid, thyrohyoid divisions are part of the muscular layer of the middle layer of the deep cervical fascia. These divisions extend between the hyoid bone and the clavicle, enclosing the infrahyoid or strap muscles. From a surgical perspective, this layer is important because it divides in the midline, giving access to the deep structures such as the trachea and thyroid gland, making it useful anatomical landmark during procedures like tracheostomy or thyroidectomy. However, in terms of clinical infection, this layer is not commonly involved in the spread of infection as it primarily encloses superficial muscular structures. Buccopharyngeal fascia forms a covering over the pharynx and esophagus, and it plays an important role in separating these structures from the prevertebral fascia that lies deeper. Superiorly, it is attached to the base of the skull and inferiorly it extends down into the thoracic cavity. This facial layer helps redefine the retropharyngeal space, which is a potential space that is clinically important as a pathway for infection spread from the neck to the chest. Pretracheal layer specifically surrounds the trachea, esophagus and thyroid gland, forming a supportive sheath around these vital neck structures. Pretracheal fascia surrounds and supports the trachea, thyroid gland and esophagus, forming a protective sheath around these structures in the anterior part of the neck. Superiorly, it is attached to the hyoid bone. Inferiorly, it extends into the upper thoracic cavity where it blunts with fibrous pericardium. Laterally, it is in relation to the thyroid gland and esophagus. Anteriorly, it forms the front portion of the visceral compartment of the neck. Clinically, pretracheal fascia is important because it can serve as a potential pathway for infections to spread from the neck down into the mediastinum. Retropharyngeal space is a potential space located between the buccopharyngeal fascia, which covers the pharynx and esophagus, and the prevertebral fascia that lies deeper. It extends from the base of the skull superiorly to the upper part of the thoracic cavity inferiorly. This space contains loose connective tissue and lymph nodes and is clinically significant because it acts as a pathway for infections from the head and neck to spread into the mediastinum. In deep neck infections, this space is often referred to as the danger space due to its direct communication with the thoracic cavity. Elaphasia is a thin layer of fascia located posterior to the retropharyngeal fascia and anterior to the prevertebral fascia. It extends laterally to the transverse process of the cervical vertebrae. It forms part of the posterior layer of the deep cervical fascia, stretching from the base of the skull superiorly down to the diaphragm inferiorly. Alaphasia fuses with the retropharyngeal fascia and this fusion helps define a potential space known as the danger space. Clinically, this is important because infections in the retropharyngeal space can penetrate through the alophacia and enter the danger space, allowing the infection to spread rapidly into the posterior mediastinum, which can be life-threatening. Prevertebral layer surrounds the vertebral column and the associated muscles of the neck. It encloses the following muscles: anteriorly longus colli and longus capitis muscles, laterally scalene muscles, posteriorly deep cervical muscles. In terms of its attachments, superiorly the fascia is fixed to the base of the skull, inferiorly it continues as the endothoracic fascia, laterally it extends into the axillary sheath which encloses the brachial plexus and subclavian vessels. Clinically, this layer is important because infections such as those from tuberculous osteomyelitis of the spine can track along this facial plane, potentially spreading into the posterior mediastinum. Prevertebral fascia surrounds the vertebral column and deep muscles of the neck. Carotid sheath is a tubular facial compartment that extends from the base of the skull down to the root of the neck. It encloses some of the most important vital structures in the neck, including the common and internal carotid arteries, internal jugular vein and vagus nerve. In terms of facial contributions, anteriorly it is formed by fibers from the investing fascia and the pretracheal fascia. Posteriorly, it is reinforced by the prevertebral fascia. This sheath helps protect and organize the major neurovascular structures in the neck like the carotid artery, internal jugular vein and vagus nerve. It is important in surgical procedures as it serves as a landmark, and it also plays a role in the spread of infections or tumors, since this can travel along the facial planes surrounding the sheath. In 1938, Grodenski described facial planes in the neck based on the arrangement of the deep cervical fascia. These spaces are important in understanding the spread of infections in the head and neck. Let me walk you through each space one by one. Space 1. This space lies superficial to the superficial fascia and is also called as subcutaneous space. It also contains a loose connective tissue and superficial structures. Space 2. This space surrounds the cervical strap muscles. It lies superficial to the sternothyroid-thyrohyoid division of the middle layer of deep cervical fascia and is between the sternohyoid-omohyoid and sternothyroid-thyrohyoid divisions. Space 3. This space is superficial to the visceral division of the middle layer of the deep cervical fascia. It includes the pretracheal, retropharyngeal and lateral pharyngeal spaces. Space 3A is a subdivision that corresponds to the carotid sheath. Space 4, this is the space between the alophacia and prevertebral fascia of the posterior layer. It is also known as the danger space because infections here can track from the neck down to the posterior mediastinum. Space 4A. This space lies in the posterior triangle of the neck, posterior to the carotid sheath and is part of the prevertebral space. Space 5A. This is located deep to the prevertebral fascia and posterior to the transverse process of the cervical vertebrae. It surrounds the scalene muscles and spinal postural muscles. Danger space is a potential space in the neck that lies between the alophacia and the prevertebral fascia and is clinically important because it allows infections to spread directly from the neck into the posterior mediastinum. Superiorly, it extends up to the base of the skull. Inferiorly, it goes all the way down to the diaphragm, which is why it is so dangerous. Infections can travel from the pharynx to the thoracic cavity without any barriers. Laterally, it is bounded by the alophacia on one side and the prevertebral fascia on the other. This space is filled with loose areolar connective tissue and closely associated with vital structures like vena cava, aorta, thoracic duct, trachea and esophagus. Because of its direct communication from the neck to the chest, infections in this space can rapidly become life-threatening, making early diagnosis and management critical. That concludes the discussion on the anatomy of facial spaces. Let's meet with another interesting topic. Thank you.